Good evening, everyone. Welcome to what I think is going to be a very exciting night, where we'll get to spend the next hour on a very important topic. So my name is Herb Chen, and I'm going to be moderating this session, and we're so honored to be asked to participate from the American Journal of Surgery. And I'm going to ask each of the participants to introduce themselves and let them explain what tonight. And I'll start with our illustrious speaker, Chelsea.
Hi, I'm Chelsea Harris. I'm a general surgery resident at the University of Maryland and one of the co-creators of the curriculum.
Justin.
Hello, everyone. My name is Justin Dimmick. I'm the chair of surgery at the University of Michigan, and I am a fan and supporter of the cultural complications curriculum developed by Chelsea and Leslie, who will be speaking tonight. And I think we are an early adopter, and I'm here to share some perspectives on what I think we did well and some things that we could have done better, and sort of where we're still working to improve our implementation of the program.
Fantastic. Leslie?
Hey, I'm Leslie Dossett. I'm a surgeon here at University of Michigan. I'm the vice chair for faculty life, and I'm going to share some of our perspective on some of the nuts and bolts of implementation, as well as lessons learned.
And then Gifty.
Good evening, everyone. I'm also a surgeon here at the University of Michigan. I'm almost done for my second year on faculty here, and I'm also in the role of assistant collective director for our surgery medical students. Today, I'll be sharing my experience being in the audience during cultural complication sessions at the University of Michigan. So happy to be here.
Fantastic. And so how it's going to work is for about the first 20 minutes, Chelsea is going to give us a presentation. And then we'll have a moderated discussion where we'll ask you, the audience, to participate in 3 polls. And we'll have a discussion around those that we will pose to you, and our panelists will then give their viewpoints. And we'll have probably about 10 or 15 minutes left for questions at the end that we'll take from the audience. And you can either, I think, post them in the chat room, and I can read them out. And then we'll hopefully conclude in an hour. We'll let you enjoy the rest of your evening. So without further ado, Chelsea, do you want to kick us off?
Well, thank you so much for the kind introduction. And I'm so excited that everybody is here this evening and that we get this opportunity to talk about our experience and disseminate this curriculum that we worked so hard on. So before we dive into the real nuts and bolts of what the cultural curriculum is, and what we've been doing to implement it, I would like to first acknowledge my own context and talk about the space in which this curriculum was created, because I think that will impact how it's used. So as you can all see, I am a white woman, and I grew up in a small town in Vermont, this is the yearbook composite from my senior year. And as you can see, that's about as homogenous an environment as they come. I have no training in critical race theory, sociology, or any real formal discipline related to this topic. My forays into this really started during my general surgery training, when it became evident that my gender was playing a lot bigger role in my daily interactions with patients, attendings, and staff than it ever really had in my own conception of myself, and more than I'd ever really wanted it to. In other words, I started paying close attention when it started affecting me. Thankfully, through a combination of dedicated self-education and some really excellent teachers, I have been able to expand beyond my own perspective and through a variety of identity factors. However, I will readily admit that when it comes to discussing lines of difference, I still often feel uncomfortable in this space. I make mistakes, I worry about making mistakes. Should I do so this evening, I welcome feedback on how I could do better in the future. But I want to acknowledge that you don't have to be an expert to start making a difference in your own life and possibly the life of your colleagues. The other important contextual element I want to talk about is, although the majority of you are probably here because the national conversation is really taking a close look at racial inequality, as it currently exists, gender is the much more predominant through line for the curriculum. And this is for a couple of reasons. So the seeds of the curriculum were planted as a call to action from the Association of Women Surgeons. They developed the He for She Task Force, which was meant to teach surgeons how to be allies and leverage partnerships to improve equity for all. And the cultural curriculum emerged in part as a response to that. As we will demonstrate when we dive in, the didactic portion of the curriculum really aims to be succinct, easy to interpret, and highly data-driven. And my experience when I was trying to pull the data for this together is that there is substantially more scholarship about gender differences than there are on any other line of difference. And having actually tried to conduct some of this research myself, I would wager that that's because to a large degree, gender is externally identifiable. You can pick someone's gender based on their photo and the pronouns that are used in their biographies, whereas things like race, religion, sexual orientation require self-identification, which requires surveys, and we all know how good doctors are at responding to surveys. So I'm hoping that as DAI work continues to really gain support and rigor, that this will continue to improve, and I am already trying to add more, but if you're looking for a one-stop shop to educate yourselves or your faculty about racial inequalities, you may be disappointed with this curriculum. So with those caveats, let's dive in. As we began to conceptualize how to improve culture and build allyship, we also began to think really critically about why diversity training fails. One of the main reasons we came up with was a lot of it is a just check the box online tool. And everybody hates that. I care deeply about this topic, and my primary goal when I'm forced to complete online DEA training is to click through as quickly as possible. Another major issue with the online modules is that the information that they confer is often transient, and the only thing anyone remembers is how long it takes to complete. Example-based curricula can also be alienating. I can't tell you how many cultural trainings I've attended that are aimed at a mixed group of doctors, and every example of bad behavior uses a surgeon. And so I'm sure we've all witnessed surgeons having bad behavior in the wild, but when the whole training focuses on one group, it's really easy to flip from a receptive context to a defensive posture, and the message gets lost. I think a lot of the same things happen when discussing lines of difference. Similarly, training is often focused on the extremes. And I think we all know that manifestations of overt sexism, racism, homophobia, transphobia certainly occur. Subtle displays of bias, such as failing to recognize a woman or a person of color as a doctor, are a lot more common, and in many respects are actually harder to address because it can be challenging for the recipients to parse out whether quote unquote actual discrimination is occurring or if they're just being sensitive. And this can also make reporting or calling attention to such behavior challenging because offenders are not always conscious of what they're doing wrong, and recipients might feel like if they report that could be seen as overreacting. So training that doesn't speak to this reality therefore misses a big part of the problem. DEI training also comes in single big chunks in the form of annual retreats or seminars, and let's face it, it's hard to hold anyone's attention for a whole day or even a half day, and without constant reinforcement and re-education, hard to sustain change. Also, a lot of it is not actionable. There's a lot of awareness raising in these trainings, but what to do next is often a lot murkier. And if the training focuses purely on the extremes, you might get a strategy for something that happens once or twice a year and be left with nothing for the things that you encounter on a day-to-day basis. Furthermore, it's all well and good to train the learners, but culture is often a top-down affair. In a highly hierarchical medical environment, setting the culture and the degree to which a department invites or promotes change can stem directly from the leadership. And a leader who believes in this message can be a really powerful agent for improvement, but there are many contexts where DEI might not be seen as particularly valuable. More broadly, I've found that in a lot of the voluntary DEI stuff that I've attended, there's a lot of preaching to the choir. In other words, the people who are in the room already believe in the message and are doing the work, and the people who actually need to see the message or hear it and change their behavior are nowhere to be found. So with these shortcomings in mind, we began to brainstorm about how we could do better. And thanks in large part to Dr. Dossett's experience with Michigan's Culture Club, what bubbled to the surface was that we needed to attend to cultural error in the same way that we attended to medical error. And that was where the idea for the cultural complications curriculum was born. So our proposal was that once a month, in place of a standard medical complication, we would present a case of cultural error, but we would attack it in the same way that we attacked the medical error. That is, we would go into the science of why it occurred, discuss how we could respond better, and try to build systems that reinforce this change. And to our minds, leveraging M&M was particularly powerful because the format was going to be familiar to the audience and its rigor was widely accepted. We thought that the combination of case presentations, didactics, group discussion was ideal because the cases would raise awareness about the behavior and help reinforce the idea that DEI issues were neither abstract nor isolated to the ever nebulous outside hospital, but a reality of the patients and the providers' lives around us. We also hope that the didactics would establish a shared scientific basis and that the group discussion would help establish best practices. We also felt like M&M was an ideal forum because it could be longitudinal and because it was one of the few places where all levels of the departmental hierarchy, from students to the department chair, congregated. So as we began to operationalize our idea, we also had to think fairly critically about our audience. To our minds, there were four major groups. A small set of early adopters, who I mentioned already believed in the message and were actively doing the work. A much bigger group of potential allies who were perhaps sympathetic but unsure how to act. The potentially convertible, those might be people who were skeptical or maybe weren't really aware of the concepts. And then a final group who could be presented with RCT level data and would never believe that what you're saying is important. We decided that the bulk of the change could be focusing on those middle two groups. And that was important because it impacted our tone. So I would guess that most of the people who are involved in diversity, equity, and inclusion work, myself included, are here because we passionately believe that it's a moral imperative. But there's some thought that couching your approach in moralistic or social justice language can be a substantial deterrent for people. In other words, if you say, we need to change our hiring practices to hire more people of color to rectify centuries of deliberate exclusion perpetrated by white male elite, that risks immediately being translated to, we're going to unfairly lower the bar to hire more people of color. And that is neither true nor helpful. So we elected to borrow Scott Page's approach, as highlighted here in his book, The Diversity Bonus, to try to make our argument from the place that, not from the place that DEI was the right thing to do, but that it was the smart thing to do, and really make a data-driven case for why that was so. And because of that, our touchstone became to build the case that increasing diversity or changing culture doesn't undermine the meritocracy, rather it's central to making it function. So what did that amount to? So we identified 12 core topics in DEI. These can all be found at our website, which I will promote at the end of the talk. But we sort of broke it down into some foundational topics, some identity-specific topics, professional development, and how to sustain diversity. So each session defines key terminology. It reviews the foundational science and where it exists, evidence-based response strategies. And then in an effort to really accurately reflect the reality of the science, we also purposely discuss some of the flaws of the data and the context in which it might not be applicable. Finally, every module is fully scripted, so presenters require minimal a priori familiarity with the topic, and each presentation can be delivered in under 10 minutes. So like traditional M&M, the heart of the curriculum is the cases. The case bank includes hypothetical scenarios that draw from the contributor's personal experience, existing literature, and social media. And we purposely selected a wide range of perceived levels of harm to avoid including only the most egregious examples. And we also had a real intention in making a standardized case bank because we wanted to avoid any of the accusatory overtones that can occur if people think that these are cases drawn from their audience and specific people are being called out. However, we hope that they're close enough that it accurately reflects the audience experiences, and by creating space for people to talk about them, that people who may have been unaware or unactivated can see that this really is a problem in their home institution. And then ultimately that will raise enough awareness that this kind of behavior is not acceptable and hopefully decrease its overall incidence. Okay, so now I've convinced you that the curriculum might be useful to evolve your culture. So what can you learn from our experience thus far? So first off, and as you probably all understand, and that's why you're here tonight, is that you need to leverage your context. There may be places where it doesn't take a crisis to push for radical change, but I would guess that in many more, because change is hard and power structures are entrenched, deviation from the usual order isn't always welcome. So if you're working in this space, I encourage you to leverage these pivotal events for all that they are worth, because resources are finite and attention spans are short. The other thing is, if you are somewhere towards the bottom of the hierarchy, as I very much was when I tried to institute this, is you need to find a local champion. There's going to be some eye rolling. Not everyone will be a fan. However, a champion, particularly someone in a position of power or who is perhaps outside the standard go-to diversity structure, who can introduce the curriculum and lend some backing, sends a strong message that this work is important and may help dampen some of the more vocal critics who could create a chilling effect on group participation. And while having backing at other institutions is also helpful, I would say that you really need to have someone at your place that is going to stand up for you if you anticipate that this might be a little bit controversial as well. This also speaks a bit to who should deliver the talks. I think the Michigan folks have really done it right, and they started with the department giving and the departmental leaders giving the talks first, and this sends a message that yes, this is important. And then they've opened it up to residents and students, which helps create an environment where everyone feels that they can participate in the discussion. I'll get into this in a little bit, but at Maryland, our rollout was a bit more contentious. So I have been delivering all of them because I didn't want to put anybody else in the position of having to defend the curriculum. Thanks to some great clinical champions, my understanding is that the rollout at Michigan was actually fairly smooth, and I'm sure my co-panelists will speak to this, but my experience was a bit rockier. Most notably, when I opened up our inaugural session, one of the first questions I got was, why are you wasting M&M time with this? Now, I'm happy to report after a lot of work, the reception has warmed considerably, but I would encourage anyone who thinks that they might encounter some vocal opposition to seek out those individuals ahead of time, go over the curriculum with them and try to make them part of your team. One of the mistakes that I made in the lead up to the deployment was I sent a bunch of emails, but I didn't actually put myself on anyone's calendar. And I thought that notifying emails were enough, and they categorically were not. So you need to actually talk to the people who might oppose you. And if you don't, you risk moving what could have been a private conversation to a very public one. And so in the aftermath of our somewhat rocky debut, as I was trying to play catch up and better understand the opposition, I also learned that you have to be willing to adapt. One of the primary concerns that I ran into was that the curriculum was focused very much on the provider experience, and M&M was a time for patients. So I was able to say, okay, I can look at more studies, I can find more data, I can create more cases, and I built a whole second arm that focused on the patient experience as well, so we could center them. And before I went to the next session, I sat down with everyone. I went over all of my slides. I made every change that they requested. And there are times in the darker, more exhausted times of residency where I want to stomp my feet and say that I should just be allowed to do it my own way. But if you're unwilling to compromise and bend to include your critics, I think you may end up being shut out entirely. There are also less confrontational ways that you need to be willing to adapt. At Maryland, the concept of implicit bias or microaggression was fairly new to a lot of the audience, so we really needed to build a common language and a common knowledge base before we could discuss the case. In contrast, the surgery department at Michigan had been discussing these topics for years, so when they started the pilot, their audience didn't really want to spend a lot of time on didactics, and they wanted to spend a lot more time discussing the cases, and they were able to adapt the curriculum to fit those needs. Now, when people request it, we still send them the we still send them the fully scripted curriculum, but I would really encourage you to adapt it to the specific environment and shorten or expand various portions as you need. You also have to be thoughtful about how you're going to cultivate participation. We recognize that jumpstarting discussion on thorny topics can be a bit tricky. So to help, each case comes with some suggested prompts. Much like medical M&M, we include prompts on how the individual could have responded better, how the team or the group could have done something differently, and the systems that need to be built to reinforce that change. However, I would suggest that early in deployment, when you're still trying to cultivate participation in a large auditorium, and you may have some people who are on the more skeptical side, you might want to let a few people in the audience know what the cases or the prompts are ahead of time. And this is not necessarily to create a propaganda machine, but it's so that people can make coherent thoughts and respond thoughtfully to your prompts, and that will help jumpstart some of the discussion and maybe avoid a situation where if the reception is a little chilly, nobody talks for the next couple. It's also important to understand your ask. So unfortunately, academic medicine remains a pretty homogenous place. So when you're talking about issues of diversity, equity, and inclusion, the natural tendency might be to draw from the same people over and over again. And this repeat sampling is taxing in and of itself. But as we discuss in some of our modules, success in academia is often tied to conforming to the standard mold, and that's often an agentic, white, hetero, cis normative environment. So asking members of your community to highlight aspects of their identity that they may have actually tried to suppress or downplay to succeed in their environment may be unwelcome, unfair, and in some cases unsafe. Furthermore, being expected to be the voice of your entire population can be really difficult, and it isn't a good practice to make those people do that over and over again. So at the same time, one of the things that I've personally struggled with is how do you educate yourself or your group without pretending to speak for someone else? For example, we have a module on intersectionality. That is the idea that being a woman of color brings with it a different set of challenges than those experienced only by women or only those of experienced by people of color. And so as you have all seen, and as I've explained, I don't really have an intersectional identity. So when I was going to deploy this, I approached several members of my department to see if they wanted to present it in my place. And to be truthful, none of them were very enthused about doing so. And so we had to figure out a way that I could be true to their experiences and some of the concepts that they wanted discussed, but I didn't necessarily put them on the spot. And so we landed on having them be in the group discussion. And I think that worked for that specific session, but I still feel a fair amount of uncertainty about how to best make space for people to share their experiences without making certain people consistently responsible for the education of their peers. It's also important to understand your ask, and I think we'll get into this a little bit in the panel, that tapping into your trauma in a situation that is public and short is a pretty big thing to ask people to do. 20 minutes is not a lot of time, and there are some participants who feel like they've opened up this wound and then are expected to go right back to their clinical duties, and this can be particularly challenging if you don't necessarily have a great response strategy. So we are still sort of working on how to fix that, and whether that's identifying faculty members ahead of time who might be interested in continuing the conversation offline, or having voluntary groups later in the evening to pick the conversation and back up, or everybody's favorite self-directed online learning. But I encourage anyone who is wanting to implement this curriculum to think about how they're going to address that particular process. And then finally, we are still working on measuring our outcome. So hopefully as we get more institutions on board and come up with our strategy, that we'll be able to survey the curriculum, and our hope is over a long term create some qualitative arms to delve deeper into it as well. I think one of the other things we are trying to figure out is how to, after we have such great discussion, pool best practices and redisseminate those back out to the group. So those are things that are still under construction, and we are continuing to actively refine. So with that, I will say thank you for listening to our introduction. The website's below, www.culturalcomplications.com, which I think I have misspelled here, and I'll be happy to move into any questions. Dr. Chen, I think you're still on mute.
Thank you. I'm muted. Chelsea, thanks for a fantastic talk. I think this gets our conversation started, and we'll move into the next phase where we're going to push out our first poll question. And ask you to participate. Is your institution ready to implement a cultural complications program? And if you can click on your answer, we'll give you a few seconds to click on it, and then we'll tell you what the 102 attendees on this webinar have answered. Okay, it looks like 77% of the attendees said they're ready, 23% no. So let me pose the first question to Justin. So what do you think are the necessary components of a culture or department before you can implement such a program?
Thanks for the question, Herb. So first I just want to thank Chelsea. That presentation was really amazing, and even having been along there watching it unfold in real time, you described it incredibly well and with great nuance. So thank you for that. Regarding the question, I was really happy to see that the majority of people said that they were ready. And I think Chelsea in her presentation said, gave a good idea that this can be a difficult thing to implement. And I will say, I'll start out by saying that when we launched this at Michigan, it was last summer. I had been a chair for, I think, a few weeks. And when we decided we were going to launch it, and I asked Leslie Dossett who should be moderating this? And she turned to me and said, you. And I was like, oh boy. So I'll tell you, I had a great deal of trepidation and went into this essentially afraid that I was going to say the wrong thing or that I didn't have the right skills. But in navigating that, we thought that it was really important to have the department leadership leading this initiative because of the potential for pushback or eye rolling and those sorts of things. And so I'd say that the components for readiness, even though I'll readily admit that I didn't feel ready and that I mostly was afraid when we started doing this. I'm not afraid that it wasn't a good thing, but afraid that I would say the wrong thing. And I like how Chelsea started right out with that. If you're going to engage in this work, you have to be open to making mistakes and open to learning from those mistakes. Those are two absolutely tenets for readiness. You're not going to come into a new space and as a non-expert and not make mistakes. So I think that comfort with that is really important. But I think that probably the number one component for readiness is having the leadership say that this is a value of our department and come down hard and talk about it publicly and be a champion for this. I think that probably is really important. I think that it's just really incredible that a resident could launch this and have the courage and strength to do that, and to the maturity to work through converting people into supporting it. But I think having the chair and senior leadership in the department buy in and believe in it and believe in diversity as a core value and message that I think is really important, because there's a lot of cultural work that needs to be done there, understanding where your culture is falling short, because all of our cultures are falling short every day. And you have to understand where it is and be able to create spaces to discuss that and to learn from that so you can improve. And what I like about this is that it does create that consistent longitudinal space that everybody has to enter. This isn't just voluntary. It's important that everybody hears these discussions and everybody learns from these discussions, and that everyone's perspectives are enriched by these discussions. I feel strongly about that, which is why I like having it in this format. So I think that those are the things that you need to, if you're going to launch this, you need to have leadership, buy-in ideally, and support. You need champions throughout who you can use as facilitators to make sure that discussion is launched. I'll tell you, once our discussions launched, they were incredibly rich, and we essentially ran out of time for all the people that wanted to talk. And there was argument and there was disagreement, fairly tense conflict in this setting, but it was not crickets. There was a lot of people eager to share their perspectives and their experiences. So I think those are the components for readiness. We had been, as Chelsea alluded to, we've been working on educating our department on implicit bias, and we had grand round speakers. And I think a lot of that, what that did was change how people wanted to engage with the material. Instead of having didactics, people wanted to go right to the cases. Like they did not need kind of what is implicit bias, because we just had several lectures and workshops on that over the last year or two. So we eliminated that based on feedback and went right into the cases from the beginning, and then spent the whole time discussing the cases, which allowed us more time to get to action items. We spent a lot of time talking about, how would you handle the situation, or how could you handle the situation better? And those are the richest part of the discussions. I think you'll hear from other panelists tonight that really allowed for people to go back to the wards and go back to their teams with some tools and even phrases or conversations or frameworks for thinking through how to manage implicit bias, microaggressions, whatever it is, in real time.
So I know having it that you have it and place one of your M&Ms, and often I think for people's M&Ms, attendance is limited to people because of confidentiality and stuff. And there's a question in the chat box: do you open these sessions to people other than people in your department or people who you would have at your grand rounds?
Leslie, you want to take that question?
Yeah, I can take that one. So we usually do a case as part of a broader session where we will discuss a normal clinical complication first. We usually don't have 100% seats of, bodies and seats at 7 o'clock. And so I think that's to launch him to one of these discussions first thing is a little bit difficult. So we've had most success doing a standard clinical complication first, and then the second half an hour on a cultural complication. So for that, it's the same audience. Some other departments across Michigan Medicine have trialed this as well, but we primarily keep it to our usual M&M audience.
Thanks, Leslie. Gifty, do you have any comments about the implementation and some of your observations?
Yeah, so as I mentioned during the introduction, this is almost my second year here on faculty. And the reason I came to Michigan was because I was attracted to the Michigan Promise. And when I had interviewed here, that was something that had been highlighted a lot. And I remember going to the website and reviewing that and noticing that one of the missions of the Michigan Promise was to build a diverse, inclusive environment where all faculty and students could thrive. I think part of that Michigan Promise, one of the efforts or focuses had been creating spaces, safe spaces for people to have such conversations way before I arrived here. And it's been very gratifying to see that continuing. I think that's one of the reasons why the cultural complications seem to fit in naturally, because already through the Michigan Promise, that conversation had already started. And it seemed as if people were already on board and eager to learn more. I also think that the Michigan Women's Surgical Collaborative had already begun that journey too. I remember my first year here, we had a he for she session, and it was insane the number of people who attended that. I think there were more people at the he for she session than even like the main event. And again, that just shows, I think, how the culture, people were already in that mindset and that space and willing to take on this challenge. So I found the cultural complication sessions to be quite easy. It's interesting hearing Chelsea's experience and seeing how that was completely different from what I noticed here with it.
Oops. There's a question, thanks Gifty. There's a question about Tracy Wang here in the chat box that Justin answered a little bit, but I think that the concern or the question is about the virtual environment and how that might affect the interactions. And I think probably you guys have had the experience of having it sort of in person and virtual, and maybe share, if any one of you wants to share some of the differences or things you've had to adapt to potentially in the virtual environment.
So I will say we are just picking up our M&M again, and we sort of have a backlog of actual cases. But when I gave a version of this talk recently, and we sort of did one at the end of it and went through it. And I think it comes, one of the things that's going to be effective, whether you're in a group or in or virtual, is to identify some people ahead of time who are willing to speak on the topic, and that will help break some of the ice in the virtual format. And in the live format, that you have people who have thoughtful responses that can say, yeah, this has happened to me too, and here's what I did, here's what I wish I had done, here's something I've observed that I thought was, oh, that's a really great way to do it. And that way it starts getting people ready and willing to talk, and having kind of a deep bench of prepared individuals can be very helpful.
Justin, you want to add something?
Yeah, I just wanted to say that in response to Tracy's question, so we're two things. We're trying to figure that out as well. You know, we kind of went to a bare bones M&M when we, during COVID, and haven't restarted in-person meetings yet. So we're launching our own virtual as well. But what I wanted to say was, one of the purposes of doing this webinar is to get other people engaged in this so we can learn and share best practices and share ideas across institutions, because there's a lot of challenges, and I'm really interested in cultivating a community of people working on this, whether we do working scientifically to study it, to improve it, or just sharing best practices. So Tracy, once you launch it, please give us some feedback and let us know, and we'll do the same. There's a question in the Q&A that is from anonymous attendee, and this is a really important point. The question is, how safe is making mistakes now? People are losing their jobs over the statement. And all I'll say to that is that people are losing their jobs, I think, because they didn't lean in and learn how to lead in this space, right? This is leading. If we accept that diversity is both the right thing to do and the smart thing to do, learning to lead to a diverse organization is a critical leadership competency for everyone. And learning to lean in and make mistakes, make small mistakes, I think, prevents you from making the big mistake that may cost you your job. That's my perspective on that. I'm interested in other people's perspectives, but I didn't want to let that question go by because it's a really important question.
Gifty, did you want to add to that?
Yes. So, when someone hears cultural complications, I think the first thing that jumps into their minds is this racial discussions that have captured our attention recently. But as Chelsea pointed out, it's interesting because most of the curriculum reviews or discusses other DEI issues and then even explores that intersectionality. And I have found myself, like, the first time I was in a session, I was like, I know this, I've lived this, you're talking about me here. But then I found myself in other sessions where I was like, oh my gosh, I actually don't know this. We had one on gender change, transformation. You can see even I don't know what the correct words to use to describe that is. And then being in that room and then finding myself like mumble jumbling along with staff, other faculty and other students, trying to be PC, but at the same time being like, we need to talk about these issues. And we were making mistakes, but it was in this joint process of trying to learn and then creating this safe environment where it was okay to show, to some extent, our ignorance and then to be educated about it. I think it depends on where the intention or the heart behind some of the statements and comments. I think you can tell when people want to learn and when people are trying to just be aggressive and put other people down. And what I've loved is that young and old, we are all in this space making mistakes and we are learning. And it's fine. And I still have a lot to learn, clearly, because I still don't know how to describe the gender change transformation thing.
Great. All right, I know that you can keep your questions coming in the chat box. Our panelists are answering both there and also verbally. So I'm going to move on to the next poll, and we'll get that poll going. Is what do you believe are the biggest potential benefits to implementing a cultural complications program? And your choices are to educate the audience of issues of bias, to provide anti-bias training, to allow team members a forum for discussing experience bias, or other. And so we'll ask you to make a selection here. Great, and let's see. So it looks like the leading one is to educate the audience of issues of bias, followed by to allow team members a forum for discussing experienced bias. And so I'm gonna start with you, Gifty. You've mentioned this a little bit when you've spoken on the other topic, but again, what do you see are the biggest positives of doing this from your 2 years of being there?
I must say, I think we are in this new situational environment where, again, race discussions have been on the up and up. The frustrating thing about that is that when there's an event, everyone talks about it. There's a lot of hype around it. There's a lot of conversation, and then it dies away. And then people who actually live in that situation get frustrated. They feel like everyone moves on and they're still stuck in that space. And I felt like the cultural complications allowed us to have a steady discussion. It held us accountable to like learning and then trying to improve instead of having these like peaks, huge peaks and huge valleys, long valleys. And I think that was one of the biggest positives or advantages to me. Again, having been someone who came here because I believed in Michigan's mission to improve the workforce for folks who look like me and have all these like intersectionalities going on. It was important to see that consistent discussion being delivered. The other thing that happened was, and I was talking to a resident of mine earlier on today during a case, and I asked for his opinion about the sessions. And then he said, you know, it's interesting to see extroverted people speaking out loud and sort of like taking control of the conversation. But as an introvert, just being in the room and listening, he had walked away with, you know, scripts or stuff to say when a situation presents itself. And I can bear witness to this. Last week, actually, I had a nurse ask me if I was a nurse, even though I was scrubbed and wearing my white coat and everything, when I went to see a patient of mine, and I was there with my resident. And then before I could say anything, my resident stepped in and he's like, no, this is the attendant, and went on and on and on. And I guess and it was like really refreshing, you know, it's like, oh my gosh, someone else is doing this work for me now. But I think, again, it's a reflection of the fact that we have been having these discussions. They felt comfortable speaking up. They didn't wait for me to sort of, because it's like, do you speak for the person who is being attacked or not? And they were just like, we're going to correct the wrong here because we see ourselves as an ally. And I think that has been definitely a huge positive of this program.
Oh, it's very well said. So you mentioned, so the ongoing sort of conversation. And so there's a question in the queue about, you guys have chosen to do it at M&M with the whole, I guess, department. Did you think about using smaller venues, like divisional seminars are doing in smaller groups? Any thought that any of you want to comment on versus a large group?
So I can speak to this a little bit. When I first faced some pushback, one of the solutions that someone had offered was, well, why don't you just start with the residents? You can get some time in education and you can just do the residents. And that was actually one of the biggest pieces that I pushed back against because for a lot of reasons. One, I felt like in a lot of respects, the residents were actually a little bit further along in knowing these terms and doing this work than some of the faculty was. And that I felt like, especially in something like surgery where it's very hierarchical, that you really needed a little bit more top-down help, or at least some more top-down awareness. And so I think to the extent that you can push to get it in big group things, the better off you will be. The other side of that is, as part of the being adaptable, I think something is better than nothing. So if it's going to be a non-starter to have it be in your M&M, or you can even bundle a couple of them and do it in grand rounds, then you can take what's given to you. And I think there may be some benefits in the small group discussion that it will allow people to open up and delve in a little bit further. Sometimes diving into some of the harder aspects of your identity in a public forum, particularly one that maybe has a history of being a bit antagonistic, can be a little bit challenging or unwelcome for some participants. I think there may be some bonuses for that, but I think targeting parts of the department that include your hierarchy is critically important.
We have sort of two questions about, I mean, you answered one of them, Chelsea, about doing it potentially at grand rounds. You alluded to this could be added to. And the other question comes, what about doing this across a service line versus a department? Any of our panelists want to take that one on?
Yeah, I can address that one. I think you could certainly do either. One of the things that I think has been really powerful about these sessions has been the degree to which we acknowledge that all of these cases, we use hypothetical cases, and there's a question about that in the Q&A, but we use hypothetical questions, but every single case we have presented has tremendous face validity across our department. There are always people that raise their hands, say, this has happened to me, this happened to me last week, or we've had in several cases, allies, say, if you think this doesn't happen here, you're not paying attention. And so I think any environment where, lots of these issues like sexual harassment from patients, or we did one case about, a patient saying they didn't want to be taken care of by a Mexican doctor. All of these things happen across our hospital. And I think, these are issues that transcend departments. I think the value of the department, there's pros and cons to all these approaches, but the value to doing it within the department is that there is, some familiarity and trust. We have these difficult conversations in this forum about clinical complications. These are often, we're often vulnerable about our own clinical errors, and so it's an environment we trust to have these conversations. So that's worked for us. But I think if you have that similar level of familiarity and trust across service lines, I think it could work. I do think you have to have some kind of trust for people to be willing to open up and participate.
Yeah, and I will say, so we don't necessarily always have the most robust discussion in the auditorium. There's a couple of people who respond, but it doesn't seem, from what I've talked to my partners at Michigan, it doesn't seem to be that really robust debate. But one of the things that I've found really heartening is I've gotten a lot of feedback that the conversation continues outside of the auditorium. So people are talking about this in the OR. And I had one of my attendings come up to me recently, and he was like, when you first started this, I thought this was really fluffy and irrelevant, but I've heard people talking about it, and I've asked my fellows and my residents, and they're experiencing this, and I'm starting to pay attention, and I think that this is actually a lot more important than I initially gave it credit for. And so even if your group discussion is not as fruitful as maybe you, the presenter, are really cheering for, I think it helps spread the discussion elsewhere, and people find the individuals that they think are safe, and we'll talk about it and figure out strategies. And as that kind of percolates through your department, I think that also has a role in changing behavior and building allyship.
All right, we have a question about how you get leadership to support efforts coming from a trainee, and obviously, Chelsea, you had that experience. Maybe you can provide a little bit of that, and then Justin, if you want to comment how you were convinced to do it, or how, if advice you have to talk to other chairs of how to convince them to do it. So why don't you go first, Chelsea?
Sure. So I will say I had this idea kind of at the end of my second year of research, which is I was at Michigan, and I met these wonderful people, and then went back to my home institution and was like, hey, I have this great idea, we should do it. And then I had crickets basically the entire year as I brought it up to multiple people, and nobody really was all that excited about it. And then, to be honest, we landed on the front page of the Baltimore Sun for a sexual harassment lawsuit. And then when the national attention was on that, all of a sudden people were a lot more receptive to implementing something to show that we're making change. And so I think leveraging your current contacts to say, like, one, this is a conversation that's happening at the national level, and if we are not doing something on this, we're falling behind. This is something that our prospective faculty are going to be asking about. This is something that our prospective trainees and students are going to be asking about. And you can really kind of make it a recruiting tool and demonstrate the value added. I think, as Dr. Dimmick spoke to, that if you're not leaning into this learning and change, one, you may risk your own job, but two, you're going to be falling behind in terms of the innovation of surgical departments across the country. So I think making a clear case to your gatekeepers about why this adds value, and then trying to find an ally who will back you up in that. So for me, I brought it up through my traditional leadership, but then another committee was formed to sort of better respond to sexual harassment things, and Dr. Sherry Slezak, who was the chair of plastic surgery, so not necessarily integrally related to general surgery, M&M, said, no, I'll back this and I'll stand up for you for it. And that was the in that I needed. She went to my chair said yes. Part of it was we had some leadership changes at the top during the part that this was rolled out, so it now has a slightly more friendly aspect, but I think getting multiple partners and really having a clear proposition as to why this is valuable and not just fluffy nonsense that's taking the place of traditional science is going to be a really critical part.
Justin, any comments about how convince? I know one thing you could do is tell your chair that Justin Dimmick is doing it, and then that'll get a lot of them to change. But do you have any other thoughts about how leadership can be convinced to enact something like this, Justin?
Well, I mean, one of the things that I'm trying to do and with this webinar is to put peer pressure on other chairs to do this, right? And to call it straight out that this is a leadership competency. It's something that I'm uncomfortable with, but leaning into. And I'm hoping that if we tell them Herb Chen's doing it, and more and more chairs across the country are doing it, and I think that's our job, Herb, is to help lead our colleagues to understand the value of this work and to continue to lead change at our level. As a junior faculty member, as I said before, I think credit to Chelsea for just figuring out how to get it done. It's because it's really hard if you don't have buy-in from leadership, or you're getting, the eye rolling or those types of non-supportive behaviors. I think it's really hard to navigate that. I think that they should get somebody compelling in front of them if you can, right? And like have Chelsea give that talk she just gave as a grand rounds or something like that, or Leslie or this whole Leslie and Gifty and Chelsea to give a grand rounds or something like that, because if you listen to the arguments and the data, it's really hard to set it aside. And I think find allies, as I said, I think find the most receptive, most powerful person in your department and start to engage them. And that's the best way to implement change. There's another question here that I wanted to briefly touch on. Is Sherry Wren. So she's doing this next week, so thanks, Sherry. Speaking of powerful allies, also fearless. Sherry, you said how to introduce this. So I think that what I did was I started by saying that we come together to learn about to learn from our clinical complications. We show humility and talk about how we could do things better. And we need to do the same thing for our culture, because our culture needs improvement. And if we value cultural improvement like we do clinical improvement, then we need to discuss our errors and learn from them. And that's kind of the little spiel I gave when I introduced it. Because we actually did a clinical case, and then I gave like this transition that we were going to pilot this curriculum, and that's how I introduced it. Then we went to the cultural complication.
And I would be happy to put a script on the website if people think that would be helpful for how the leadership could introduce it. And we did the same thing. We have our M&Ms generally are 15 to 20 minutes apart, and we have 50 minutes to present them. And so we generally do 2 regular M&Ms, and this is the one that we end on. And also ending on it kind of helps people have an opportunity to continue the conversation if they would like to.
Let me just ask one question. I know we have only a few minutes and I still have one poll to do, but have you guys thought about doing a real case now that you've had these scripted cases, using a real live example of a case?
So we
you've done live?
We have deliberately avoided that because we didn't want it to be finger pointy, and they're close enough that everyone's like, oh yeah, no, that's happened to me also.
Leslie, have you thought about using real ones or Gifty?
Yeah, we have, but I think for the same reasons, like you really don't have to use a real case to, I mean, the cases that we've done so far are common, sexual harassment from a patient. We've had, when we did that case, lots of people, said they had experienced that. All of the cases have, like I said, hypothetical cases, all of them have had a lot of face validity without dealing with the, confidentiality issues that you have with real cases.
And with that, if people have things that they think would be really useful to discuss, you're welcome to submit them via the Cultural Complications website or email me directly or Twitter, and I can start adding them to the case banks. There's about 3 per topic on both a patient-focused and a provider-focused, but I'm more than happy, as residency time allows, to start banking more of them.
Great. In the last few minutes, I'm going to go ahead and initiate the last question so we can get our last poll done, because I think this question is a lot of people want to briefly discuss, at least, what are the biggest barriers to implementing this program? And we've discussed some of them, but you can see the choices listed there. So those of you who anticipate some barriers, what do you think the top one will be? And then after the poll is done, I'll ask Leslie to go ahead and comment on perhaps how to transcend some of these barriers. And we've discussed this a little bit, but maybe Leslie can give some closing thoughts as we're thinking about all starting this. It looks like pretty spread, but evenly, but lack of expertise and lack of support. So Leslie, do you want to comment?
Yeah, so a couple things. We're still working through some of these barriers, but in terms of the lack of expertise, for those of you who haven't had a chance to look at the website, like Chelsea has put in so many resources. There's lots of things that you can read to increase your own expertise, but we've also for a couple cases invited an expert to be in the audience. As Gifty kind of alluded to, we did one case. We do a lot of gender affirming, or plastics department does a lot of gender affirming surgery. And we did one case on misgendering of a patient in the PACU. And so we had, experts from plastic surgery that take care of these patients that are way more familiar with these topics to be in the audience. And so that's one way to get around the expertise. And then in terms of the discussion, learning from Chelsea's experience, one of the things that was very helpful that we did was, for the first couple cases, we had audience plants. So people that we shared the case with ahead of time, and we asked them to be prepared to make a comment or ask a question. And that really got the discussion kind of off and, going, and avoided that sort of awkward silence at the beginning. And so that's something that I would strongly recommend for the first few. We don't need to do that anymore. People are comfortable and jump in, but it was very helpful in the beginning.
Gifty or Justin, do you want to comment? Gifty?
Yeah, I was going to say, one of the comments in the chat room, is getting people to talk initially. I think there's a little bit of an activation energy thing that has to happen, and you need that first person to say something once the case is presented. And once that happens, then everybody starts opening up and then sharing. So I think that is a potential barrier, even in places where people are receptive or open to the idea of having these talks. The plant is an excellent idea because that person can launch the conversation. And having been a plant once in one of these situations, even then it was like, oh, when do I go? When do I go? When do I say something? But yeah, so there's that activation energy. But having a great moderator really helps, because then they can call from the crowd and then just get people engaging.
So a lot of questions about where the webinar will be on the website that you provided. And then are your contact information on the website if people want to ask you questions and everything?
I think, I'm not actually sure I put our email addresses up. I'm happy to type mine into the chat at the end. I'm also on Twitter at CA Harris MD. You're welcome to DM there. And if you submit, there's like a request the curriculum thing on the website, and that gets forwarded directly to my email. So I will respond to all of those directly as well. So if all else fails, you're certainly welcome to do that. I think we are very much still in the active process of trying to figure out how to evaluate how well this is going, how to pool best practices so we can redistribute them. And I'll try to, as we come up with a better strategy to do that, to feed that back onto the website as well, so people can look there for strategies.
And so with our last minute, I just want to thank everyone for participating. It's been fantastic. And I think that we all can watch, people who weren't here, we can distribute the webinar, but I think Justin offered you all up as a live presentation as well, right? To be invited by anyone who wants you guys to do this live. Am I not, I did hear that correctly, right, Justin? You offered that?
Well, as long as it's a grand round, so they can put it on
Yes.
their.
And I think, you know, giving this live and perhaps, you know, putting describing the cases and stuff would be a great way for any institution to kick it off so they understand, you know, the content and how you guys deployed it and the importance of it. So it looks like it is 8 o'clock in Central, 9 o'clock Eastern. So we've spent an hour with you all. And I, again, appreciate the opportunity to moderate this super panel that we've had and the great discussion. And as Gifty said, hopefully this discussion will continue, not only here, but in all of your institutions. So thank you, everyone. And we look forward to seeing this at many more institutions throughout the country.